Thank you, everyone, for attending what I think is one of the most premier neuromodulation courses available in the world. And then also thank you for tuning into this presentation. I'm Dr. Stephen Falowski. I'm a functional neurosurgeon out of Philadelphia, Pennsylvania in the United States. My practice focuses on spinal cord stimulation as well as other avenues for implanting electrodes in the body, such as deep brain stimulation and peripheral nerve stimulation. On this talk, I'm going to focus on intraoperative neuromonitoring, not just for its safety and its efficacy for placement of electrodes, but also for its future, looking at waveforms, mechanism of action, and also how it correlates with ECAPs, or evoked compound action potentials, and what's known as closed loop systems. These are my disclosures. Specifically to my talk, I do consult and perform research for numerous companies that will be discussed in this presentation, including Abbott and their waveforms, as well as Saluda and the closed loop system. I think it's important to start with a background on intraoperative neuromonitoring for spinal cord stimulation. This is a movement that has been present in spinal cord stimulation, especially in the United States, for over 10 years now. There's a large amount of evidence to support it for both the safety and efficacy. What we have here is the NAC guidelines. NAC stands for Neuromodulation Appropriate Consensus Committee. This is a committee that meets every 2 years of international physicians to determine the guidelines for spinal cord stimulation, as well as peripheral nerve stimulation and intrathecal therapies. In 2017, this was landmark for intraoperative neuromonitoring in the sense that the guidelines now stated that there was only 2 ways to place a spinal cord stimulator. It's either in a completely awake and cooperative patient, or if the patient is going to be sedated, you have to have a form of intraoperative neuromonitoring for safety, as well as confirming that the lead is in the right location. What the guidelines was trying to demonstrate was that we didn't want a middle ground where patients were being sedated and we could not monitor them for safety, and we couldn't appropriately determine that the leads were in the right location. So let's start with a little background on intraoperative neuromonitoring. This is something that is very commonly used by spinal surgeons in many of the cases that we perform. And it's used for safety or spinal cord protection to give us a warning if something is going wrong and to make sure that we perform the procedure appropriately. However, with spinal cord stimulation, we not only need this safety aspect of making sure the spinal cord is protected in an asleep patient, but we also need to confirm or physiologically map that the electrode is in the right location. If you look at all the companies presently on the market and all the waveforms that are available, all with the exception of one are still physiologically mapped on the spinal cord. And we know that traditional tonic stimulation as well as these other waveforms work better when appropriately placed onto the spinal cord. So that extra aspect that we needed with intraoperative neuromonitoring beyond safety was to be able to physiologically map the difference between anatomic or X-ray midline and physiological midline, actually where the middle of the spinal cord is. We know that from work by Holsheimer that there's a discrepancy in where the spinal cord is approximately 40% of the time, and that the spinal cord can be off to the left or to the right in that percentage of time. There's also the potential benefits of using intraoperative neuromonitoring since the patient can be asleep. Some of these benefits include less stress to the patient and the surgeon. It's a more predictable procedure when you don't have to worry about unwanted patient movements. And then there's also this element of time and accuracy, which I'm going to get into, that intraoperative neuromonitoring can improve upon compared to awake placements. Over many years, several papers have been put forth in publications to demonstrate that intraoperative neuromonitoring works. In 2016, this is a paper looking at the actual protocols that can be used, not just for safety, but more importantly for confirming that the electrode is in the right location. We're going to get into more descriptions of how this is done later in this presentation, but essentially we use EMG or motor activity that can be elicited from the spinal cord stimulation to determine that we're in the right location, which is an example of what you see here. There were two hallmark studies that were performed looking at the use of intraoperative neuromonitoring for placement of spinal cord stimulators. The first was a very large retrospective study looking at 167 new implants, comparing awake placement by the same surgeon who transitioned to a sleep placement with intraoperative neuromonitoring. And then in 2018, we had a multi-center prospective trial directly comparing awake placement against a sleep placement with intraoperative neuromonitoring. What I'd like to do is dive specifically into the results of the prospective trial. These results mirrored exactly what we saw in the initial retrospective trial in 2011, but these are the findings from the 2018 publication called the NAP study, which was the prospective multi-center analysis directly comparing awake and asleep placement. What I want you to see here is we went through multiple factors and time points to determine this comparison. So we looked at the time in the OR, how many times did we have to reposition the electrode to get it into the right location, as well as any adverse events. And what you can see here across the top of the screen is the time in the OR. So the first piece of it that we looked at was how long it took to wheel the patient into the procedure room or operating room compared to when we can actually make first incision. And what you can see here is, and this will hold true through all the time points, is that it was 25% faster to do this in an asleep patient with intraoperative neuromonitoring, making the procedure more predictable and streamlined. We also looked at the actual procedure time, what is called skin to skin time, or from when you started incision until when you closed. We also saw over a 25% reduction in the amount of time when using a sleep with intraoperative neuromonitoring. So obviously, when you put these two together, the total operative time was also approximately 25% less when doing this asleep with intraoperative neuromonitoring. So as you can imagine, there is very much a time savings that can occur by using a sleep with neuromonitoring. Now, we also looked at the programming. Once the electrode was placed on the spinal cord and we wanted to physiologically map or determine that the electrode was in the right location, we determined how long it took to do that programming. And what you can see here in the top right for intraoperative programming, you can see a dramatic reduction in the time it takes to do the programming and determine that the electrode is in the right location. If you look on the bottom part of the slide in the middle, it looks at how many times was the electrode in the operating room repositioned to get it into the right location. And what you can see is with the asleep patient with intraoperative neuromonitoring, the electrode was repositioned 2.5 times more. However, even though it was repositioned more times to get it to become more accurate, you can see that the programming time was still significantly reduced, meaning that we're able to test faster and determine the location of the lead faster with each testing when you're asleep with intraoperative neuromonitoring. What it also shows, though, is that since we repositioned it 2.5 more times with intraoperative neuromonitoring in a more efficient manner, we were trying to get improved accuracy of placement with the electrode. And then very importantly, if you look on the bottom right of the screen, we have the adverse events, any side effects that occurred. And what you can see here is that there was 1/5 of the adverse events that occurred in the asleep group as compared to awake placement. So not only is there a time efficiency, not only a more accurate lead placement, but we reduce the adverse events down to 1/5. Some of the other factors that we looked at was also pain control, and to ensure that the pain control is at least equal, if not superior, between one of the two groups. And what we can see here by looking at the NRS pain score as well as the subjective pain relief, you can see that trending it up to the 24 weeks, patients in the asleep with neuromonitoring group trended to be significantly better for pain scores and subjective pain relief, demonstrating that the more accurate placement that we had led to improved outcomes. We also looked at quality of life measures, the EQ-5D, and demonstrated that the patients were much happier with the asleep with intraoperative neuromonitoring group. In the bottom right, we looked at the precision of generating paresthesias when placed in a traditional tonic parameters. And what we demonstrated was that we had more precise uh, placement of the electrode in the asleep group with intraoperative neuromonitoring, that we could focus in the paresthesias where it needed to be and not have extra paresthesias in locations we did not want. Now, I want to fast forward a little bit and talk about the present research that's going on moving into the future. So at this point, large intraoperative neuromonitoring is largely used in the United States. And it's partly because of these studies that showed improved efficacy, time efficiency, and less adverse events with it. But now I want to move forward into some of the more research-oriented things that we're doing with intraoperative neuromonitoring. In 2018, there was a publication where I looked at the different waveforms that are available for spinal cord stimulation. At this point in time, different companies offer different ways of stimulation, and most of these parameters are either sub-threshold or paresthesia free. But all of these waveforms work by a different mechanism. Some of them work by higher energy requirements, while others work under lower energy requirements and less stimulation to the spinal cord. So what I decided to do was to place all these different waveforms under intraoperative neuromonitoring to determine what would happen differently. How do the nerves of the spinal cord in a real human being act differently? Now, it's important to realize that with spinal cord stimulation, we actually have never recorded real human nerves to determine mechanism of action or what actually occurs with spinal cord stimulation. So this is the first study to look at real human nerve recordings with spinal cord stimulation. What I'd like to do first is give you a little background on how we physiologically map the electrodes in traditional tonic parameters, which is how we presently map it to the midline of the spinal cord to make sure we have proper paresthesia coverage. We use what's called an H reflex. What this is imagine when you touch a hot stove, you pull your hand back right away. The reason you pull your hand back right away is the sensory input was so large into the spinal cord, you generate a muscle response even before you realize that sensory input came in. We do the same thing with the spinal cord stimulator. Once the electrode is in place, we turn on the stimulation at higher levels to look for muscle contraction. The penetration of the signal will go from proximal or superficial to deep in the spinal cord. If you look at those fibers, that means it would normally go from your hips to your thighs, all the way down to your feet, and would go in that progression with the higher you turn up the stimulation. So what you see here is an example of one-sided coverage on the left side. You see each line correlates with a different muscle group, starting with your abdominal muscles, your hips, your quads, your tibialis anterior, followed by your foot on the very bottom part of the picture there. And what you can see is it's a one-to-one response. As we turn up the signal, you get one EMG spike, and it's going to progress from those superficial muscles to the deeper muscles. So what you see here is the top three muscle groups have been activated, which is the abdominals, the the hips, and then the quadricep. If we continue to turn up the stimulation, it would penetrate deeper into the spinal cord until we got to the foot. So what I also want to show now is we started looking at the different waveforms that are available and different stimulation sequences that are available to see what would happen differently under intraoperative neuromonitoring and being able to record these electrodes. Well, there's presently what's called the burst DR waveform, which is a very specific 5-pulse sequence that creates a burst of activity. Now, what you can see here on the picture is that 5 pulses that are being delivered. However, unlike what you saw on the last slide, where there's one-to-one response, where each signal generates a response below it, you don't see any response below this 5-pulse sequence. It's almost at this point the 5-pulse sequence is not being registered by your nerves in the spinal cord. Or there's also what we consider a charge accumulation. These 5 pulses are building up. It's not to the 5 pulses stop and we have a rest phase, that we actually start to see the spinal cord responding. Now, this is quite interesting because that means that the spinal cord is responding after the stimulation has gone through. What's also more interesting is that the first fibers to get activated were the deepest fibers in the spinal cord, the foot fibers, not the hips or the quadricep or thighs. What we saw was actually with this 5-pulse sequence, the deep fibers were activated first, and they were activated at very low levels of stimulation. So this is a highly energy efficient waveform that penetrates deep into the spinal cord. This works by a very different mechanism of action when compared to traditional tonic stimulation. Now, we have also looked at some of the other waveforms on the market, which was called cycling. What this is taking traditional tonic stimulation and turning it on and off in alternating patterns. This is as compared to the 5-pulse sequence, which is a true burst of energy in a specific 5-pulse sequence. This is where you now turn tonic stimulation on and off. And what you can actually see here is that when you turn tonic stimulation on and off the 4 times, it has a 1-to-1 response, just like traditional tonic stimulation does. This is what you would expect, being that we are turning traditional tonic stimulation on and off 4 times. However, one of the things that we did see with this cycling is that the responses do come in at lower levels of energy. However, this is offset by the fact that you have to repeat it 4 times to generate that response. Now, I want to show you another interesting phenomenon that we saw under intraoperative neuromonitoring for this study. We demonstrated that when the spinal cord was exposed to the burst DR waveform, or that 5-pulse sequence that was highly energy efficient, generating deep fiber activation, we saw that the spinal cord actually became very hyper-excitable, or the thresholds for which these nerves would be activated were dropped tremendously. So what you see here on the top half of the screen is when we're stimulating with traditional tonic parameters at approximately 8 milliamps. And what you can see here on the top part of the screen, on the left is the left-sided muscle fibers, and on the right is the right-sided muscle fibers. We're getting activation 1-to-1 on each side, left and right, and it's going in the top 3 muscle groups, which is your abdominals, your hips, followed by your quadriceps. Now this is at 8 milliamps. At this point, we would turn off the stimulation. We would turn on the burst DR waveform, the 5-pulse sequence that is a high burst of energy, and then go back to regular traditional tonic programming. And what you can see here on the bottom half of the screen, the same patient after receiving burst, when was given traditional tonic stimulation, had much higher fiber activation. In fact, you can see that all 5 muscle groups, both left side and right side, are being activated. This was activated at less than 4 milliamps. On the top half of the screen, it was at 8 milliamps. So what you can see in the same patient, the nerves became hyper excitable. The thresholds were dropped when it was introduced to the burst DR waveform. In the paper, we describe this as a priming effect, where that burst DR waveform, or that 5-pulse sequence, can drop the thresholds of the nerves so that the nerves can listen at much lower stimulation to the next signal that's coming in. This is very important for the future when we think about stuff like energy efficiency for generators. If we're able to hyperexcite the nerves at much lower levels, we can save energy on the generators. In addition, we should be able to now excite nerves that we were not able to stimulate before because of elevated thresholds. So now I want to fast forward another year into the research. After this has now been established that some of these waveforms have a very different mechanism of action, hyperexcitable effects, penetrating deeper in the spinal cord at much lower levels of stimulation. The next step was to look at, if you made changes to the waveform, would it still have the same effect? More specifically, we looked at the burst DR waveform of that 5-pulse sequence is run at 40 hertz. It's already a highly energy efficient waveform. However, what if we were able to change the frequency, keeping the 5-pulse sequence, but instead of running it at 40 hertz, run it at 30 hertz or 20 hertz or 10 hertz? Will it have the same effect? And what we actually demonstrated was it does have the same effect with very little change in the amount of stimulation that's needed. This is extremely powerful physiological data because what this was able to show was that you could decrease the 40 hertz to 10 hertz. So a fourth of the energy that was being delivered to the spinal cord could still have the same effect. So now you can imagine a non-rechargeable generator, how long it could last with this type of energy savings. What's more important though, when I look at this data is what we're starting to see is we can actually gather recordings from real human nerves on the table, determine mechanism of action of waveforms, determine how not only how they work, but whether they can work in different stimulation parameters. And then once we determine that from actual physiological real human nerve data, we can go back and then do clinical studies that are more guided and less trial and error because we have real human nerve recordings. I think this is also a very interesting study that took intraoperative neuromonitoring even a step forward. Not only looking at the signals within the spinal cord, they looked at the signals on the cortex, most specifically the sensory cortex as well as the frontal lobes of the brain. And what they actually showed was that based on the stimulation parameters that you use, whether it's traditional tonic, higher frequency, or burst stimulation, you could actually lead to different cortical changes in the brain. And we're able to record this in the operating room in the asleep patient. And what they actually showed was that under burst stimulation, the changes occurred in the frontal lobe of the brain, not just the sensory cortex. The sensory cortex is what we would always expect with traditional tonic or paresthesia-based systems that generate tingling sensations. However, the frontal lobe part of the brain is where you perceive your pain. How does your pain affect you? And what we showed was that in the burst stimulation, even under intraoperative neuromonitoring in an asleep patient in the operating room, we could see changes in the frontal lobe of the brain. Now let's take this a step even farther forward. There's the advent of what we call ECAPS, which is an evoked compound action potential. What this is looking at recordings from the spinal cord as you're stimulating. It's a closed loop system. So right now we have what's called open loop, which is a fixed output system, meaning when we place these electrodes, we turn on the stimulation, but we don't actually know what's occurring at the spinal cord. Are we overstimulating? Or are we understimulating? How about when patients change position, sit up, lie down, and the electrode moves farther and closer to the spinal cord? For every half millimeter that the electrode moves, you can lose or gain 50% of the signal. That's tremendous when you think about the fact that we cough, we sneeze, we move throughout the day. So therefore, your stimulation is changing every moment of the day. You can potentially be moving in and out of having a therapeutic effect based on this. So what the ECAP is, it gives us the ability to have a closed loop system where we can program the devices and also record from the spinal cord the action potentials that are generated. And we know that when we generate a certain action potential, that it can equate to pain relief with the patient when we clinically program them to talk with them. So the question is then is if we can constantly keep the closed loop system and record the action potential, we can also adjust in real time to keep this action potential the same while changing the stimulation. So what that means is we'll keep constantly changing the stimulus based on the fact that the electrode's moving closer and farther away, but always keeping the response the same. That's from at the spinal cord level, so that we know we're always generating the proper response with the action potential. So then the question is if we use the action potential as a marker of spinal cord activation, how can we intertwine this with intraoperative neuromonitoring? So now we have this concept with intraoperative neuromonitoring of using recordings of the real human nerves in the periphery, as well as traveling through the spinal cord, as well as even from the cortex to determine mechanism of action. But now what about the objectiveness of stimulating the spinal cord? Could we use ECAPs in the operating room in an asleep patient to determine we're getting the best response from the patient for pain relief? So what you have here is a multi-center study that was put together utilizing the closed loop system with ECAPs, but correlating it with intraoperative neuromonitoring. What we were able to show over multiple patients in this multi-center analysis was that we could correlate some of the findings and recordings from the spinal cord with the position of the electrode on the spine. So what would be the benefit of this if we could stimulate and record from the same electrode? The benefit is when we use intraoperative neuromonitoring now, we have to hook up electrodes and EMG leads on the patient while they're asleep. If we could stimulate and record off the electrode, potentially we would not need to place these electrodes on the patient. We would not need a technician to run the neuromonitoring setup in the operating room. In fact, we could have a completely objective lead placement in the operating room based on the stimulation and recording of these ECAPs. Now, this could very potentially be the future because if you imagine now, we can also determine even responders on the table for the future. If we are able to generate the most ideal action potential, objectively know that we're on the middle of the spinal cord and that this is the best response you're going to get with this waveform, clinically we know the patients who are going to respond. Now, this is very much in its infancy of looking at that. What we were able to show, though, in this study is that we could objectively map or physiologically map how close the electrode was to the midline to ensure that we were getting proper positioning of the electrode. Now, the way we did that is by looking at two factors. One is what's called the ECAP, which we discussed with the action potential, which is a marker of activation in the middle of the spinal cord. But if you look on the picture in the middle, not only do you see the ECAP, but there's a second response that comes on later, a second blip in the recording. This was called a late response. And until this study, no one was sure what that recording actually stood for. But what we were able to show on the intraoperative neuromonitoring is that late response correlated with the EMG activity that we would use to map out the location of the electrode. So when we turned up the stimulation and we would get those muscle responses, knowing that we put paresthesias in the thigh or quadricep, they would correlate with the late response. So now we know that the first activation of the ECAP would be midline. The late response is the nerve root or the EMG response that's coming out later. Now the question is, if we can put those two together, could we objectify placing the lead to know how close we are to the midline? So the answer to that question of whether we can objectify placing the lead is yes. What we did is we determined that if the ECAP was a signal of stimulation on the middle of the spinal cord, and that late response was the nerve root or EMG response that we get with neuromonitoring, we can look at it as a ratio. And what we would determine is we wanted that ratio to be greater than 1.5. So that tells you that you're closer to the midline than you are to the nerve root. Now, what's interesting is this has also been clinically seen where we look at what is the tolerance level of paresthesias for patients before they get a nerve root or unwanted stimulation. And 1.5 is what we saw clinically. The higher that ratio, the more likely you are to be on the midline. So what you can see here is an example of us increasing the stimulation and generating that ECAP. Eventually, you get the late response later, and we look at that ratio. The way we can tell we were too far lateral is if that ratio dropped less than 1, because the late response or the nerve root response comes in prior to the midline response or ECAP. So what you can see here is the same thing, us raising the activation. We have a late response followed by the ECAP. We were able to do this across the top and the bottom of the electrode, and we can tell which part of the electrodes were spanning midline versus going more lateral. Here's an example of when the stylet is in the electrode and the stylet has the tip of the electrode going out lateral. What we can actually see is that on the top of both of these electrodes, the ratio drops significantly lower, and most specifically the one on the left here, a ratio 1.35. This clinically correlated when we woke up the patient with unwanted nerve root stimulation. And what you can see on the bottom of the lead, when you look at the numbers here for the bottom of the lead, the ratios are greater than 2, showing that the electrode was actually on the midline. So hopefully you can start seeing that there's a lot of research that we can do with intraoperative neuromonitoring, being able to record real human nerves with spinal cord stimulation, not only determining mechanisms of action, not only potentially making a safer, more accurate procedure, but there's implications for objectifying spinal cord stim later and eliminating the subjectiveness that we have. We've now taken intraoperative neuromonitoring a step further, looking at dorsal root ganglion stimulation, or stimulating single DRGs, or the brain of each nerve coming into the spinal cord, and able to map out where the DRG is located in the most perfect position to place the electrode. So now we can also place DRG electrodes in asleep patients to have improved safety, but then also guide our lead placement for these patients as well. And there's been several studies that have been demonstrated here. One of these hallmark studies was a prospective study directly comparing awake DRG placement against asleep DRG placement. In this study, the patients were used as their own control. So the electrodes were first placed asleep and then followed by using intraoperative neuromonitoring to see if the lead was in the right location. We looked at both sensory and motor thresholds. The reason being is we know with the dorsal root ganglion, we're looking for sensory effects, while the ventral portion would be motor or unwanted place for the electrode. So the importance is we would want to have sensory responses without motor. So what you can see here is how we determine those thresholds. If you look on the left side of the screen, we look at the muscle activity. And you can see that on the final muscle, the L5 dermatome, which is the third muscle there, there's still a blip at 3.3 milliamps. As we lower the stimulation, that on the right side there, you can see that we dropped it to 1.5. The muscle response goes away, but we still have recordings of the sensory response. This gives us the ability to know that we're on the sensory portion, or the DRG, and not in the ventral portion of the foramen. We've now taken this steps further with multiple studies and being able to map out the exact locations of the DRG to position the electrodes perfectly for the best chance of the stimulation working. So I think in summary, it's important to see that we're moving towards objectifying spinal cord stimulation. Even at present, pain scores are very subjective from the patient. We have no objective measures of knowing that the electrode's in the perfect position, or that this is the perfect waveform for the patient, or this is the perfect action potential generated on the spinal cord. But now, with the advent of intraoperative neuromonitoring really pushing this forward, and as well as ECAPs, or these evoked compound action potentials, we're starting to see that we can not only improve outcomes with spinal cord stimulation, improve time efficiency in the OR, decrease adverse events, but we're also objectifying lead placement. We're determining mechanism of action of how these different waveforms work. We're able to guide clinical studies now from real human nerve recordings. Eventually, what we're going to see in the future is this will be completely objectified, and hopefully we'll be able to determine the responders to spinal cord stimulation based on their response in the operating room with these real human nerve recordings. Thank you, and I really hope that you enjoyed this presentation. More than available to answer any questions anybody may have, and my email will be available. Thank you.